Bismillahirrahmanirrahim. Quote of the day is every soul shall taste death. My name is Dr. Amna Khalid. I am PGR Community Medicine and I will be presenting the topic of cholera under the kind supervision of Professor Dr. Saira Afzal, who is Dean Institute of Public Health. So the learning outline for today's presentation is Introduction to Cholera, the epidemiological determinants, clinical features, phases and complications, diagnosis, prevention and control measures, global and national burden, recent advances, and then the practice of MCQs. Cholera is a severe diarrheal disease that can be fatal within hours if not treated, so quick access to treatment is crucial. It's caused by consuming food or water contaminated with the bacterium Vibrio cholera. Global health, global public health threat, and indicates inequity and lack of social and economic development. And access to safe water, basic sanitation, and hygiene is essential to prevent cholera and other waterborne diseases. This is the epidemiological history of the disease. At first, it was identified in India. There has been seven pandemics since 1871 of cholera. The seventh pandemic started in 1961 and it originated in Indonesia. Current pandemic is mainly caused by Vibrio cholera O1, the EI Tor biotype, which replaced the classical biotype, and the new zero group O139 emerged in 1992 in India or Bangladesh. So we will go through the disease transmission. The reservoir are mainly humans, but contaminated water and marine environment can also harbor the organism. Mode of transmission is fecal-oral route, contaminated water and food are person to person indirectly, and poor sanitation. Incubation period is very short. That's the reason of outbreaks as well. That's a few hours to 5 days. Period of infectivity is infectious as long as the organism is excreted in stool and usually during acute illness, and it may continue for several days after recovery. So we will go through the agent, host and environmental factors. Vibrio cholera is the causative organism. It's a gram-negative bacteria. It has two main serogroups, O1 and O139, which cause the epidemics. And biotypes are classified into classical and EI-TOR biotypes. It produces toxin called cholera toxin, the CT. It's motile and comma-shaped bacteria. It survives in the water bodies and can persist in the brackish water and plankton, and sensitive to drying, heat, and acidity, and is killed by chlorination. So only two serogroups of Vibrio cholera are there, which causes outbreaks, the O1 and O139. The Vibrio cholera O1 has caused all the recent outbreaks, and Vibrio cholera O139 caused outbreaks in Asia in the past, but has recently only been identified in the sporadic cases. But overall, the clinical picture is same in both the cases. These are the host factors that, including age, all ages are affected, but children are more affected in the endemic areas, and adults are affected in the epidemics. Immunity, previous exposure gives partial immunity, and breastfeeding protects the infants. Gastric acidity, low gastric acidity leads to increased risk. Nutritional status, malnutrition increases the susceptibility, and vitamin A and zinc deficiency also increases the severity. Food handlers, fishermen, and people living near contaminated water sources are more vulnerable to get the disease. These are the environmental factors like contaminated water, poor sanitation, overcrowding, or in case of the disasters, warm, rainy seasons, poor infrastructure, lack of sewerage, limited access to healthcare. These are some major clinical features of the disease: profuse watery diarrhea, rice water stools, vomiting, thirst, muscle cramps, especially in the legs, Signs of dehydration, we will go through it further, including sunken eyes, poor skin or turgor, weakness or fatigue due to fluid loss. These are the three phases of the disease: prostration phase, collapse phase, and reaction phase. In the prostration phase, there is sudden onset of watery diarrhea along with vomiting. Rapid dehydration starts here, and thirst and weakness is there. In the collapse phase, severe dehydration occurs, sunken eyes, hypotension, cold clammy skin, weak or rapid pulse, and it can rapidly progress to shock and death. Then comes the third stage, the reaction or recovery phase. Rehydration starting and gradual improvement occurs, and urine output returns and appetite returns, and diarrhea stops in this phase when treated. So the complications can be divided into the early and delayed complications. Early complications occur due to acute fluid and electrolyte loss and include severe dehydration, hypovolemic shock, acute renal failure, metabolic acidosis, hypokalemia, and hypoglycemia, especially in children. Delayed complications occur due to prolonged dehydration or improper management. It and includes acute kidney injury, cardiac arrhythmias due to electrolyte imbalance, including hypokalemia, persistent malnutrition in children, secondary infections, and death if it's untreated. These are some of the differential diagnoses. Acute gastroenteritis due to the viral cause, including rota or norovirus, food poisoning due to staphylococcus or clostridium, typhoid with diarrhea in the early phase. Similarly, amoebiasis and shigellosis can also present with watery diarrhea in the early stages. Giardiasis and ETEC, that is enterotoxigenic E. coli infection. Diagnosis is majorly clinical, based on the symptoms we have already discussed, that there is watery, rice water stools, vomiting, rapid dehydration, and there is history of contaminated water exposure. But if you ask about the what lab tests are the options, that includes stool culture that is gold standard, isolation of Vibrio cholera using the TCBS Agar, and a sero group is identified. Then we have a rapid diagnostic test RDT that is used in the outbreaks, and it's useful for early screening. Then we have microscopy, dark field microscopy showing motile Vibrio cholera, the bacteria, and then PCR, if it's available. This is confirmatory, and it is available in the research or lab settings. So now we go to the prevention. The first of all, we have primary prevention that prevents the disease before it occurs. Oral cholera vaccination in the high-risk areas, and then health education and awareness regarding safe drinking water or chlorination, proper sanitation and sewage disposal, hand washing and personal hygiene, and food hygiene. These are the three WHO pre-qualified vaccines named Ducarol, Shankol, and Uvicol. All of them have two doses. Ducarol is given 1 to 6 weeks apart, and in 2 years or above age group, and it protects for a period of 2 years. Then Shankol also has two doses given 2 weeks apart, given to 1 or above year children, and it protects for 3 years. And the same pattern is followed for Uvicol as well. So as we discussed, the vaccine has two doses. Oral, it's an oral vaccine, and its the type is killed vaccine. It's used in the endemic or high risk areas or in the outbreak setting. Booster is given every 2 to 3 years in high risk areas, as the vaccine protects for around 2 to 3 years, as discussed in the previous slide. It has only mild gastrointestinal side effects. Otherwise, it's safe, and it's also safe in pregnancy and lactation. And after the two doses, an efficacy of 60 to 85% is achieved. These are some contraindications. The absolute contraindications of the OCV vaccine includes severe allergic reaction to any component of the vaccine, history of severe reaction to a previous dose of OCV. And a relative or cautious use will be moderate or acute illness. We will defer the vaccination until recovery of the disease. Then secondary prevention involves early detection and prompt treatment. So early case detection should be done. Rapid reporting and outbreak control, as it's a notifiable disease, so cholera should be notified to the health authorities immediately. Rapid rehydration using ORS or IV fluids and distribution of ORS in the high-risk areas should be done, and then contact tracing to monitor close contacts for diarrhea. Then we have post-exposure prophylaxis. It's only done in the high-risk close contacts, and it's not recommended for the mass population because of the risk of resistance to the antibiotics. Now the available options we have are the doxycycline, azithromycin, ciprofloxacin, and that depends on the age and the local resistance level of the antibiotics. And then we have the option of oral cholera vaccine that can also act as a post-exposure protection in the outbreak settings. Then comes the tertiary prevention that involves the prevention of complications and death, adequate rehydration with IV fluids for severe dehydration, electrolyte replacement, especially the correction of hypokalemia and acidosis, antibiotics in the severe cases, monitoring of the complications including acute kidney injury, arrhythmias, and shock, nutritional support, especially in children recovering from severe dehydration, and then the follow-up care. These are some of the WHO definitions. First of all, we have this definition of suspected case of cholera. In an area without a cholera outbreak, it's defined as any person with age 5 years or above with acute watery diarrhea with or without vomiting. And in an area with a cholera outbreak, any person with acute watery diarrhea with or without vomiting. Probable case is defined as a suspected case with epidemiological link to a confirmed case or RDT positive in outbreak setting. And confirmed case is defined as a suspected case in whom Vibrio cholera, either O1 or 139, is isolated from stool culture. So the management includes antibiotics that are given only in the severe cases. Zinc should be given to the children 10 to 20 mg per day for 10 to 14 days, and nutrition should be resumed as soon as possible. Continue the breastfeeding and infection control involving hand hygiene, safe water and stool disposal. Based on the classification of dehydration, um, first of all, we have mild dehydration. The clinical symptoms include thirst, restlessness, slightly dry mouth, normal pulse, and normal BP. Here we should give only the ORS. By the dose 50 ml per kg over 4 hours, and continue feeding and monitor for worsening. Sorry. If the sorry, if the dehydration is moderate and the symptoms are sunken eyes, dry mouth, rapid pulse, decreased skin turgor, normal or slightly low BP, then we have to manage it. Again, we have to give ORS, but the dose will now be 100 ml per kg over 4 hours. And we will further monitor for the ongoing losses. And we will shift to, sorry, and we will shift to IV fluids only if ORS is not tolerated. In case of severe dehydration, if the patient is lethargic or comatose, in very dry mucous membranes, weak or absent pulse, hypotension, and low urine output, we have to give immediate IV fluids with ORS, and when possible, when the patient can tolerate oral, the fluid given is ringer lactate. In adults, it's given 1 liter in 15 to 30 minutes, and in children, 20 ml per kg over 30 minutes, and it's repeated if needed. And then we have to add antibiotics in case of the severe disease and monitor the vitals and urine output closely. For the ongoing losses, as the symptoms include continuous diarrhea or vomiting, we have to give ORS or IV fluids, 10 ml per kg per stool per episode, and continue IV if needed, and a zinc supplementation for children and maintain nutrition. These are the outbreak control measures, early detection and reporting, case management, wash measures, infection prevention and control, community awareness, ORS distribution points in the community, and vaccination with oral cholera vaccine in high-risk areas. Then we move to the global and national burden and control programs. So, cholera worldwide, we can see that uh, this was the news reported on 25th November 2025, and 15,394 new cases were reported with 194 new deaths. And countries with most cases were Afghanistan, Angola, Sudan, and other countries. All right. Then we have national burden. Uh, Between January 2023 and July 2025, Pakistan reported around 21,000 suspected and 250 confirmed cases of cholera. And in the recent weekly report of 2025, NIH has reported that 7,000 suspected cases of acute watery diarrhea, including the suspected cholera, were reported. And there has been an epidemic of 2022, where 2,000 confirmed cases of cholera have been reported all over the Pakistan. This is the IDSR report by NIH, and you can see that there 281 acute watery diarrhea suspected cholera cases were reported. Then this is the public health laboratory data from the IDSR report by NIH, and the data is lacking, as you can see that it's not reported from any of the province except Sindh. These are the causes of death in children under 5, and the green line with dots show the diarrheal diseases that will also include cholera. And this is the line showing the number of deaths. These are the cholera reported cases. The data was available from 2021, and you can see that from Pakistan, 12,092 cases were reported. These are the deaths attributed to lack of access to hand washing facilities. And again, Pakistan has around 11,000 deaths due to lack of hand washing facilities. These are the deaths attributed to unsafe sanitation, and around 20,000 deaths are reported from Pakistan due to this reason. These are the deaths attributed to unsafe water resources, and around 29,000 deaths are reported from Pakistan. So Pakistan and WHO launched National Cholera Plan targeting a 90% reduction in the mortality by 2030. This is the Global Task Force on Cholera Control, working globally with the 50 plus countries working in the partnership. And it says that 1 billion people are at risk of cholera, and 21,000 to 1,40,000 estimated deaths are estimated annually. Climate change, urbanization, and population growth are likely going to increase the risk of cholera in the coming years, according to Global Task Force. So from preparedness and response to prevention and control, this is their agenda. That from cholera treatment centers, cholera kits, and emergency wash, then we have to move forward to the oral cholera vaccine with the wash strategies, and then we have to further move on to the long-term sustainable maintenance of wash. This is their roadmap. By 2030, they are hoping to reduce cholera deaths by 90%. These are the strategies to reach that level. That includes water sanitation and hygiene, surveillance and reporting, use of oral cholera vaccine, healthcare system strengthening, leadership and coordination, and that all will work with the help of community. So recent updates. This is a case study from Nepal that the hygiene promotion intervention was introduced along with the immunization program, and they saw that this hygiene promotion intervention has been effective in improving key hygiene behavior in all the districts, and the period prevalence of diarrhea among children under age 1 has gone down from 20% to 5% during the follow-up survey among the intervention group. So integration of hygiene promotion through a routine immunization program is possible, and such an approach can be adopted by other countries as well. So, according to UNICEF, Pakistan has made significant progress in the improvement of sanitation access, but still 25 million people practice open defecation, and around 53,000 Pakistani children under 5 die annually from diarrhea due to poor water and sanitation. And an estimated 70% of households still drink bacterially contaminated water. These are the solutions suggested by UNICEF, that we have to end open defecation, we have to improve the quality of water, and wash should be adopted in schools and health facilities, and as well in the emergencies. So now we move to the practice of MCQs. The first question is, a 6-year-old boy presents with profuse watery diarrhea like rice water. He is severely dehydrated and cannot drink. What is the immediate management? Option A, give ORS at home. Option B, give zinc only. Option C, start IV ringer lactate. Option D, start ciprofloxacin. And option E, oral cholera vaccine. It's option C, as he is severely dehydrated. Question number 2, during an outbreak in a slum area, several cases are reported with watery diarrhea. What is the most important primary prevention measure? Option A, antibiotic prophylaxis. Option B, mass vaccination, or improve safe drinking water, or screening of the stool cultures, or hand washing only. Right is option C. Question number 3, a patient with suspected cholera is admitted. What is the best diagnostic test in an outbreak setting? Option A, stool microscopy, or culture, or rapid diagnostic test, or stool colonoscopy, or PCR.
C.
Yes, option C. Question number 4, a child has watery diarrhea, dehydration is moderate. What is the treatment? IV fluids, ORS with 75 ml per kg over 4 hours, oral ciprofloxacin, or zinc only. Hospitalization is mandatory.
B.
Yes, option B. Question number 5, a patient has cholera. Which electrolyte abnormality is most likely? Hyperkalemia, hypokalemia, hypercalcemia, hypernatremia, or hypophosphatemia?
B. Hypokalemia.
Yes, option B is the right answer. Okay. Question number 6 is, a woman has watery diarrhea after drinking well water following flooding. Most likely mode of transmission is airborne, droplet, foodborne, fecal-oral, vector-borne.
D. Fecal-oral.
Yes, fecal-oral. A 30-year-old male with watery diarrhea, acidosis, and hypotension. Major cause of death in cholera is renal failure, or hypoglycemia, or electrolyte imbalance, or dehydration and shock, or arrhythmia.
D.
Yes, it's dehydration and shock. Question number 8 is, an outbreak investigation identifies Vibrio cholera in river water where locals bath and wash utensils. Which reservoir explanation is correct? Only human beings are the reservoir, mosquito breeding water, human and aquatic environment, poultry, or cattle. Option C is the correct answer, human and the aquatic environment. Question number 9, a restaurant worker develops watery diarrhea after attending a coastal party in the previous night. What is the usual incubation period? A few hours to 5 days, 1 to 2 weeks, 3 to 4 weeks, 1 month, or 3 months?
A.
Yes, option A. Cholera has a very short incubation period. Last question is, a 4-year-old child with cholera has started ORS therapy. Which additional supplement is recommended? A vitamin D or zinc, 10 to 20 mg per day, or iron, calcium, or vitamin B12?
B. Zinc.
Yes, zinc should be given. This is the answer key to all of the questions. This is the YouTube channel of Institute of Public Health, where this presentation will be uploaded later on. Thank you so much.
Thank you, Dr. Aamna.